Good evening, everybody. My name is Dr. Matthew Holder, and I am the President-elect of the American Academy of Developmental Medicine and Dentistry, and I'm your host tonight for the Physician Education and Developmental Disabilities webinar series, presented in partnership with the Florida Center for Inclusive Communities and sponsored by the United States Department of Health and Human Services Administration on Intellectual and Developmental Disabilities and the Florida Developmental Disabilities Council. Tonight is the fourth installment of our 12-part series, occurring every Tuesday night at 6 p.m. Eastern Time until October 9th. Each of the 12 parts of this series is accredited by the American Academy of Family Physicians for 1 credit hour of AAFP prescribed credit. This is recognized by the AMA as equivalent to 1 hour of AMA PRA Category 1 credit. Archives of each presentation are available about 1 week after the live event at www.aadmd.org. The archives are accredited for CME credit for the next 2 years, so tell your friends and colleagues they can find this online. At the end of the webinar tonight, we'll give you more information about how to obtain your CME certificate. For those of you who are not physicians, you may also use this link to obtain a certificate of completion. Just keep in mind that we are only able to award continuing medical education credit for this webinar series. At the end of the presentation tonight, there will be some time for questions, so if you have any questions during the presentation, please type them in the question box of your control panel. We will try to get through as many questions as possible during the time we have left. In our last webinar series presentation, we talked about communication, and I hope by now that we've driven home the point that it is always best to attempt to communicate with the patient directly. Aside from obtaining information, part of the purpose of direct communication is to show that you respect your patient. Or to put it another way, there is no faster way to insult a person's autonomy and value than to sit with them in a room and discuss their health and their lives and their treatment plan and never speak to them directly. This is probably best summarized in what is almost a battle cry for the self-determination movement: nothing about us without us. Now that phrase is often used in advocacy and policy circles, but it is just as applicable to the field of medicine. So tonight we're going to be discussing respect and self-determination, and we'll explore some related issues like informed consent as well. We have 2 wonderful speakers with us tonight. Alice Pomidor is a family physician geriatrician who has been in academic and community practice for over 20 years, actively teaching medical students, residents, fellows, and other healthcare professionals. She graduated with her medical degree and master's degree in public health from Northwestern University in Chicago. She completed her family medicine residency training in Northeastern Ohio at Akron General Medical Center and did her 2-year geriatrics fellowship at Metro Health Medical Center in Cleveland. Dr. Pomidor moved to Florida in 2003 and is a professor in the Department of Geriatrics at the Florida State University College of Medicine in Tallahassee. Her activities have included being medical director of long-term care facilities and retirement communities, primary care for persons with developmental delay living independently and in group homes, and also end-of-life care. She currently teaches medical students at FSU and provides wound care at Tallahassee Memorial Wound Healing Center. But our first speaker tonight is somebody who has a very different background, and I think a very interesting personal story to tell. And I'm so glad that he's agreed to share it with us tonight. His name is John Satterwhite. You'll notice that John uses an augmentative communication device, something that we talked about during our last presentation. For those of you who might have poor audio connections, we will be showing his remarks on screen as he makes them. Aside from being a self-advocate and working at a museum, John has been on the planning committee that made this entire webinar series possible, and we thought that this would be an excellent place to introduce him to our audience. So, John, if you are ready to tell your story to the audience tonight, I would like to turn the presentation over to you.
My name is John Satterwhite, and I work at the Museum of Science and Industry in Tampa. My name was John Roger Smith. I was born on September 20th, 1967 in Youngstown, Ohio. At that time, everybody thought that I was retarded, but one nurse knew that I was a smart kid. I was diagnosed with cerebral palsy. I was in an Ohio nursing home from the time I was 5 to when I was 13 years old. I was abused with a switch from a tree, and that nurse was fired. A few months went by, and then I went to school during day, and at night I was back at the nursing home. In 1980, A family adopted me out of the nursing home and we moved to Florida. My senior year at school was crazy because I was the very first student with a disability at that school. Back then the services were not good for persons with disabilities. I was determined to have a job like rest of the seniors, but vocational rehabilitation didn't want to help me back then. So, finally I got a job with my high school teacher's help. Then I had to go into a group home due to a personal problem at home. After I graduated from high school, my adoptive mom wanted to move to Hawaii, but I chose to stay in Florida and be independent. I was in a group home and my idea of being independent was new to them as well. They didn't understand it, or they were too stubborn to change to community-based services. I was shy at first and I didn't want to make any waves, but that changed when I was accused of being lazy, watching soap operas every day, and I didn't want to go to look for a job. You know, it is very hard to find a job in Florida, and especially when you have a disability. So, I got tired of people accusing me of something I am not, and I made a choice to move from a group home and in my own apartment. I failed a few times and had to go back into a group home. But I never gave up because I was determined to get what I wanted. Now, I live in my own apartment. The people at the state agencies were tired of hearing my name, but I didn't care and I still bothered them. Now, they get nervous when they hear my name and I wonder why. I didn't know that my name now has a lot of power. I am in good health, I am safe in my apartment, and I have good personal care attendance through the Medicaid home and community-based services waiver, and a lot of friends in my life. Not only do I live independently, but I am working at the Museum of Science and Industry in Tampa, Florida. I volunteered for 1 year at the museum. Then I applied for the guest service position. I got the job and I have been there almost 4 years now, but I still work part-time and do not get benefits. There are a lot of barriers in the road of success, but for now I need to educate physicians about people with disabilities health. When I was in group home, it wasn't easy when I went to doctor because the doctor would listen to the group home staff. Sometimes it was hard to make the group home staff understand about their residents' health. For example, I was sick for a long time and they were thinking that I was pretending, but somebody came up idea to take me to allergist, and that was my problem. I ended up having to get allergy shots in each arm and I am still getting the shots. When I moved to Tampa on my own, I found my own doctors. University of South Florida Medical Center knows how to treat people with disabilities right, but I saw something in doctors. If I need a Medicaid override on medicines, they don't like deal with Medicaid because Medicaid is too much paperwork and takes too long. I have to change medicines every 6 months cause Medicaid won't pay my medicines anymore. There was another time I wanted to change my allergy doctor because one nurse was very rude to me and everybody else. So I found a new allergy doctor, but she would not give me my allergy shots because I couldn't do breathing test. So I had no choice and had to stay with my current allergy doctor. But I still have 2 questions. Why did 2 doctors go ahead give me allergy shots if they know that I couldn't do breathing test well enough? And why do allergy shots help me? I need a new special mattress, but Medicare won't pay for it. I have to try everything and get a sore first before they will pay for the mattress. My doctor doesn't know what to do. We need to teach doctors how to treat people with disabilities and talk to them like typical people. It is important that doctors learn how to work with Medicare and Medicaid. Even though I work hard and keep fighting to keep my independence, I have to have Medicare and Medicaid for my health insurance. For many people with disabilities, finding doctors who will take Medicare or Medicaid is a matter of life and death. If you have any questions, please type in the chat box and I will try to answer them later.
All right. Thank you, John. Thanks for those comments. What I would like to do now is to turn the presentation over to Dr. Pomodoro. Alice, can you hear me?
Yes, I can.
Please proceed. Oh, and thank you very much.
Well, thank you all for attending this evening. You've already heard my introduction, and I do want to point out that the objectives that we're covering in this section of the curriculum tonight from the National Curriculum Initiative in Developmental Medicine are really organized into 4 major areas: professionalism, responsiveness, respect, and self-determination and consent. So we'll be addressing the objectives in sequence and meeting a couple of my patients to help us apply those objectives along the way. So our first objectives section on professionalism will be covering strategies for how to best provide health care to adults with developmental disabilities in medical offices and facilities, some examples of which you've already heard John address. The second aspect here is strategies for addressing the psychological and support needs of adults with special health care needs. And some of these I think you may see in the 2 example persons that we talk about. Regarding the objectives about responsiveness for health professionals, these are different things which we need to try to do as we provide our care on a day-to-day basis. So importantly, acknowledging the individual's abilities is critical while recognizing and respecting the specific needs that are related to their disability. Often we tend to focus more on the needs rather than on helping the person maximize their abilities and functions, and so this is something that we probably need to emphasize to ourselves. The physical environment in which we work can certainly frequently be adapted, as well as our clinical interactions, to optimize patient comfort. We need to look at demonstrating sensitivity and respect for the culturally based beliefs of different individuals with whom we are working, and then recognize that the additive impact of cultural and linguistic considerations can pile on top of a situation where most people are already placed at disadvantage and have a significant impact on health disparities. Along the way, we'll attempt to try to clarify the patient's personal meaning about their own disability and their health and life goals. John has very clearly articulated how his life goals have frequently not meshed with those that the care system supported or those that the medical system supported, and he's been a very successful advocate for himself. I'm sure we'll find that often that is not true for many of the clients and patients that we take care of. Regarding the objectives that have to do in the category of respect, part of this has to do really with our ability to feel comfortable with ourselves and how we interact with individuals and our own outlook, as well as the clients and patients that we're taking care with. So we need to be comfortable and not be fearful or anxious so much ourselves any more than we would be with traditional patients with whom we may communicate on a more frequent basis. So during clinical encounters, it's important to learn to feel comfortable with the different strategies that you use for communication and care. We need to acknowledge the value of obtaining collateral information and demonstrating respect for the team members that we do work with, particularly personal care attendants and case managers who are assisting our patients. We should be cognizant and explore the dehumanizing aspects of calling people by their disability condition or organ first. I cannot even tell you the number of times I have heard someone say, "Oh yeah, there's the cerebral palsy in room 7, rather than talking about the person who is in room 7 who has a condition or even what their concern that day is. So we can work on that a little bit more later in the talk. We need to be cognizant of using and encouraging others to use person-first language and proper disability etiquette. This actually would be applicable for every person who walks in the door, and it actually improves our communications with everyone with whom we work, whatever their permanent disability or their disability or problem that particular day may be. And again, demonstrating empathy for patients and for their families is something we probably are already hopefully doing with our entire patient population. This hopefully will just reinforce some of the principles we're all using. In terms of objectives regarding self-determination and consent, this may be particularly challenging for people who have a disability that affects their communication strategy. So making every effort to conduct medical interviews and discussions with the patient directly is essential and may require some significant adjustments in our typical routine with which we need to become more familiar. Asking about and demonstrating respect for the patient's values and preferences, ensuring that if they have a guardian, that guardian is informed and is making timely decisions, assessing the patient's decision-making competency relative to that, investigating and applying state laws relating to informed consent. And I will be covering a little bit about Florida, but everyone needs to look at this in their geographic region in particular to see what applies. This is significantly different from state to state. And then finally, assembling the legal supports necessary to obtain informed consent, whether that is directly with the patient who is in front of you, whether it's with facilitated communication at a delayed time, or whether it has to do more with the guardian who may be involved in the person's care. So I'd like to tell you first about a couple of patients who I work with quite regularly, and helpfully these two individuals will help us understand some of these objectives as we work in our day-to-day environment. It can be quite tough to use objectives in the abstract when you look at them and say, well, this is sort of motherhood and apple pie, but how do you then apply that in a take-home situation? John has given us some very clear illustrations of how these objectives may or may not have been obvious in his personal life situation. And I would encourage you to go ahead and send in your questions both to John and to myself as you go along so that we can sort of get them organized and to the appropriate person during the course of the talk and have some time to address them at the end. So having said that, I'd like to introduce you to Fred. Fred is a 72-year-old man living in one of several group homes that have access to a common workshop, school, and health center. He comes in to see me for a mobility problem resulting in 2 falls, which have reduced his ambulation significantly. He also has limited intellectual ability, limited verbal ability, intact vision, and mild high-frequency hearing loss. And I like to emphasize those because of the communications issues previously mentioned. Typically, he is calm and cooperative and goes to workshop every day. He requires supervision for all of his self-care ADLs. He formerly ambulated with a device before his falls, and he needs hands-on assistance for dressing, bathing, grooming, and transfers, moving between chair to bed, bed to table, table to device when he does try to walk. He is dependent for all of his instrumental activities of daily living, so medications, bill paying, use of the telephone, etc. are all handled by staff on his behalf. Fred can make his needs known, but he has poor long-term memory. He tends to live in the moment. Helen, on the other hand, is a younger 44-year-old woman who lives at home with 2 caregivers who come in for day and evening shifts. She came in to see me and has been coming in regularly for an irritating skin problem which is driving her crazy. She has pronounced emotional lability and difficulty with impulse control, and she tends to be limited in her abstract thinking ability, but otherwise she is cognitively intact. She is totally dependent for all her self-care activities of daily living, but can talk on a speakerphone independently. Helen does not leave her home at all on most days and chooses to spend all day in her reclining wheelchair rather than transferring, say, to a bed or to another type of chair. She has friends in her sheltered housing environment who periodically visit, and her guardian handles all her financial affairs with her caseworker. So in terms of beginning with our responsiveness objectives regarding the abilities and needs of these individuals, for Fred, for example, in terms of acknowledging how his abilities affect his healthcare interactions with our staff, he is able to give his immediate symptoms. He is able to cooperate with a care plan when it is explained and when he's prompted, and he is able to understand a simple care plan, what the goals are of his care and what we are trying to help him with. However, during any given office visit, we do need to have history provided by his caregivers. We do need to have written follow-up that goes back to his home and their assistance with helping Fred carry out the plan of care. Helen, on the other hand, is able to provide most of her history and participate in forming her care plan and understands her care plan perfectly well. She does need significant physical assistance and some emotional support to follow through on her care plan, as well as written reminders. But by and large, she is much more involved in supervising what happens with her plan of care. So in terms of the environment then, when we are adapting our physical environment at the office and our clinical interactions to optimize the comfort for Fred or for Helen or other individuals, these tips seem to be particularly helpful in making things go smoothly. First of all, we do set aside an extra time slot when scheduling our appointments to be used for helping people get set up into a comfortable position, for communicating with that individual and the extra time that often is required, creating written care plans which can go back and forth, and also having conversations with the supportive caregivers or staff. We do have designated areas in the front office which can accommodate wheelchair-level face-to-face conversations rather than someone having to look up or down over a very high counter. We do have waiting rooms which half are divided into traditional chairs style seating, and half of which is actually completely empty, so that different motorized or reclining wheelchairs can comfortably park there and maneuver. Stretchers or other different types of mobility devices are there. And we do have lifts in the back so that in our exam rooms, which can accommodate these size transportation vehicles, we can transfer people easily. We ask in return that when people do come that they bring their adaptive equipment with them. Oftentimes when people are traveling, things get lost in the flurry, and it can be very difficult to have a meaningful communication encounter when you don't have someone's glasses, hearing aids, or their word boards with them. So we have a chart system where we tag these, and when people come in to have their visits or when they call in for appointments, part of the routine of the front office staff is to remind folks that they do need to bring those devices with them and that the time slots need to be provided in addition to perhaps a usual appointment. This is an example. On the right-hand side, you see a picture, and this isn't my office desk. I wish it was, because I wish we had a couple more of these, but we do have one that's not quite as capacious, and it does provide the similar level of desk and seating. On the left-hand side, you see an exam table which has pretty good armrests for people to grab onto and help use. It goes all the way down to wheelchair level, which is where it is in the top, and then it does raise automatically with use of the foot pedal up to a height which can allow examination without having to reposition the patient quite as much. So in terms of cultural responsiveness, it's great to take into account what background people come from when you're trying to understand what their preferences may be. Fred, unfortunately, cannot verbalize what his background is, and his parents and family have died or have moved away out of the area. So he appears to have just adopted the culture of his group home, and absolutely loves McDonald's. He will ask if we have fries and Coke every time he comes in. and we try to accommodate that preference only if it's allowed by his dietary restrictions. Helen, on the other hand, says that she is Hispanic. She believes it is better to let out all her feelings during every visit, and she wishes she had a big family like the ones that she sees on TV who could take care of her instead of her paid caregivers. So during her visits, especially with some of her emotional abilities, she will lift her arms as much as she can to be hugged, and she cries frequently. She is quite emotional, and she believes that's part of her cultural background. So some of the ways in which this impacts her health care with us and our ability to care for either of them properly, Fred is now on Medicare and Medicaid, has outlived all his family resources, and really has no other options than to live in his group home and go where his insurance is accepted. So his ability and his willingness to adopt the culture of his group home has proved to be very positive for him. Helen, who speaks both Spanish and English, when she is emotional labile, will tend to break out in Spanish. Unfortunately, usually none of us speak Spanish, so it can be really difficult to communicate her needs and for us to understand her at those times. We rely on a lot of nonverbal communication, and we actually rely on experience with knowing what type of things are usually going to prove to be distressing to her and how to help her recover from that in order to help successfully get through her medical visit. So what this means that we need to be very clear about what Fred wants or Helen wants, what we feel would be optimal to have in the care plan, and then what her caregivers or Fred's caregivers feel that they need to do in order to provide optimal care. Oftentimes, medical staff have a habit of assuming that their goals are the best and that their goals are the ones which should be done because, gee, they get to write the orders and tell everyone else what should be done. And often in group home settings, they are sort of stuck with following whatever the doctor orders, or they can't do anything unless the doctor orders it. So it's really important for us, particularly in the position of giving these orders and helping write the care plans, to be very cognizant of what our clients and patients want to do. So Fred, for example, his goal is to walk to workshop and go to the monthly birthday parties as much as he wants. He is currently unhappy about not being able to ambulate like he used to. Even though he can get there with a wheeled device, he really wants to go back to doing what he used to do and be able to work in workshop in the position that he was trained in and that he's used to do, and not from a seated wheeled convenience area. His caregivers want him not to fall down anymore, and they're very worried about when he wants to get up and to accomplish something in his own way that he is going to fall again. Whereas the medical goal that we have is for him to safely ambulate. We don't want him to get deconditioned. We want him to keep his strength and keep his mobility. But we do need for the medical condition that triggered things off to be stable so that he doesn't have another fall. So what we have tried to do is point out what the medically visible problems are that need to be resolved and continually try to reassure Fred that we are working towards his goal of getting back to his previous level of ability. And his caregivers understand that this is kind of a negotiated position between what Fred wants, what we think is best, and what their ultimate goal is. Now, Helen, on the other hand, what she really likes to do is to see everything all at the same time, and she believes her chair, where she can control her mobility, is the best place to do that. Her caregivers would really like Helen to get out of the chair. Doing her personal care in terms of continence management and bathing and sometimes eating is much more difficult. And what we would like is for Helen to at least shift her positions so that the skin irritation making her very itchy and exacerbating a pressure ulcer can have a chance to heal up and have some pressure relief. So Helen, since the skin irritation is, in her own words, driving her crazy, is again willing to do some things, and the kind of negotiated outcome was for us to adjust the seating and padding arrangement that she had in her chair, which was by no means anywhere near the original casted padding that she had in her chair. It looked much more like a nest that she had decorated with all sorts of really brightly colored cloths. Her caregiver has negotiated with Helen to leave the chair at least twice a month so that different types of cleaning and laundering can be done in order to help decrease the skin irritation. And when that is occurring, then Helen is only not in her chair for a very limited portion of time, and she's placed in a position where she can still see her entire environment. So that was sort of the way in which we tried to negotiate a satisfactory care plan that would meet everyone's needs. So during their care, in terms of respecting their comfort and working with clinical encounters, you sort of need to carry over some of the same preferences and goals, mind of thinking about how to care for people on a day-to-day basis. So, for example, with Fred, he is able to access our facility with wheelchair transportation and transfer to a stretcher bed or an exam table with an assistance of one person. He does not like overstimulation and prefers a darkened, quiet room to nap while he's waiting to be seen. Unfortunately, since Fred is dependent on external transportation, sometimes he'll get picked up at 5:30 in the morning for an appointment that doesn't happen until 9:30 and will appear on our doorstep waiting to get in at 7 o'clock in the morning and may sit there for 15 or 20 minutes until one of the staff arrives to unlock the doors and let him in. So we fortunately do have enough rooms where, since he's very tired at that point, he actually does prefer to lay down and take a nap for a while until it's his appointment time so that he feels up to being seen. He will, if he arrives then at that type of time, need to use the washroom right away, and he also will ask to do that immediately whenever he's feeling nervous. So if we accommodate his needs immediately on arrival before he even goes to his napping area, then we're able to provide a plastic urinal for him. And as long as he has that available to him, he doesn't have to be anxious about having an incontinent episode during his visit and seems to be fairly comfortable. Helen arrives in her usual chair and does not move from her nest during the entire visit. So we're able to usually examine her in her chair and hold conversations and provide the direct care that we need to in her chair. She likes to always see what's going on in the entire clinic. She does understand that for privacy reasons, she cannot just stay in the hall and watch everyone as they come in and see what happens. But she really likes having her door open so that she can hear and so that she has some company until either her caseworker comes or a friend who usually arrives comes to keep her company. And we do provide a bell for her in the room so that with the door open she can ring in case she is uncomfortable or anxious about something until her friend or her caseworker arrives. She prefers to check herself in and out at our wheelchair level front desk, whereas Fred does not. He prefers to have the caregiving staff who are assisting him do all of his checking in and out. So it's been an important accommodation for our nursing staff and for our front desk staff to learn what Fred's and Helen's routines are so that they can be accommodated when they arrive and so that they can then be made comfortable while they're waiting for care. The Florida Health Passport, which I think you will be hearing about further on, is a document which I've just shown the first page of, which does help you with becoming familiar with someone's preferences in terms of communication, food preferences, and meeting their needs in terms of physical comfort and stimulation or not. I had, I think, one for each of the two folks that I'm talking about, but we haven't updated them for quite a while. What we've really done is just become more familiar with their preferences while they are in our office, which may be different than what is expressed on the Florida Health Passport that apply to a more general support environment. So in terms of then respect with team members, and I'm actually going to go a little bit more quickly through most of our remaining slides now that you're more familiar with Fred and Helen. You can see that it's really important for us to have good respect for our team members and the caregivers that assist. For Fred, since he's from a group home, he may have a float or therapy staff when they're very short-staffed, and we recognize that we need to find out who they are, their relationship with Fred, ask for their help in getting information back to his house team, and document what information we drew from the information that was sent with Fred on paper from Fred himself or versus his team members. Helen becomes very upset if her case manager is late and thinks that this implies she is not important, and doesn't always reconcile her perception of her visit time and appointments with those of the concrete schedule and those of her case manager. So in this instance, with Helen in particular, we have to be very cognizant of not kind of falling into the trap of having different team members labeled as good guys and bad guys where we're sort of set up against each other. We do want to acknowledge her legitimate concerns, but since it's important for all of us to collaborate with each other and for Helen to maintain goodwill towards the entire team, that's something that we really have to work with. With respect and dehumanizing aspects, I did talk about this a little bit before. The main thing I would like to point out here is that not only is it not even a practical or a functional thing to do, regardless of how people use the term, but for both Fred and Helen, I have not actually told you what their primary diagnoses are today. The main concern that we have for the individuals, again, is their functional abilities and the care needs that they have, and not necessarily trying to put them in a category or a slot by their disability. Sometimes that can be helpful in trying to figure out what is going on, but more often than not, it traps us in a stereotypical way of thinking. And so I just wanted to point out that particular factor. With person first language and respect, again, introducing ourselves to the person, requesting permission to talk to the others, then requesting permission from the patient to collaborate with those individuals, whether or not they want to have them in the room, whether or not they wish to have them assist with care. Making sure that if they do have someone else in the room to assist with care, that that person really has the assignment of watching for comfort for that person. Hopefully they are usually more familiar with the patient and client and can tell earlier than we as the only interval healthcare providers can tell whether or not they're comfortable. And that's important for us during the course of providing care for the person. It's also really helpful to find out whether they can give us advice on the best way to position or examine the person, especially with transfers. In terms of empathy, I think all of us try very hard to do this, and a common phrase is, "I know what you are going through." And realistically, most of us do not know what these individuals are going through unless we've been born with a similar type of developmental delay or disability. So with Fred, for example, we try to be sympathetic to the fact that he doesn't like our noisy environment, reassure him about potential incontinent episodes, and let him know that we are sorry we don't have fries and a Coke for him. In fact, we'd like to have fries and a Coke for ourselves, but we can't usually manage that either. And then ask him to do what he can to do the things that would help us with the examination. And then similarly for Helen, we try to accommodate her concerns and express that we understand that she may be anxious, that having people be late can make this worse, and ask her for her to please try to collaborate with us and hang in there with her case manager perhaps being late or not. Now, in terms of families, we also try to empathize with our families if people have their families that they identify as families. Very often, families are really the caregivers who may be unrelated by blood, the people who see someone every day, know them well, and with whom our patients and clients have a trust relationship. Even if someone is a paid caregiver, they're usually still under a lot of emotional, physical, mental, and financial strain. We're mostly raised to think in the American ideal that everyone should be able to take care of themselves after their past childhood. And so the idea that these individuals are taking care of themselves, but that they have to have a lot of other strategies and support systems in order to be as successful as they might wish to be, can be really tough. And so since families are usually the folks who are those support systems, then we really try to offer our admiration and support and evaluate whether or not people are in a position of burning out, or sympathize with them when they're not able to do what we might regard as ideal. Most people really try to do the best that they can, and the best that they can may not be the thing that we ideally would like to see done. So our role, we see, is to help support and train folks to provide respite and to help them be strong enough to care for themselves, as well as to provide support for the patient or client themselves. So with Fred, the group home that he comes from really does an excellent job of trying to follow through on things, even if they don't necessarily do it 100% of the time or can't do it exactly the way that we might wish. And Helen's friend and her case manager are really also very supportive people, and we count on them to help support Helen when she's following through on her care plan. So with self-determination as one of our objectives, we really do feel it is critical to talk to Fred and to Helen directly. With Helen, it's very clear that this is important, and we're working on the Spanish angle of this. With the Fred, he usually prefers to have his caregivers provide most of the history, because part of his coping strategy for a medical visit is to withdraw and to do as little as possible. We have checked with his guardian on this as well, and the guardian has generally said that she is comfortable with having the caregivers do this in the plan of care. The four basic principles with self-determination, which are autonomy, where people are free from interference and control, is critical. Beneficence, which is acting in the patient's best interests, and I'm sure all of us try to do that at all times. Non-maleficence, which is the old do no harm in many of the healthcare oaths, can be a little bit trickier, because sometimes treatment plans call for strategies which are uncomfortable, particularly tests which may be invasive or blood work that may cause pain. And so there's a judgment call with balancing harm against the good in an intervention, and it is very important to work with the patient or client on their ability to understand the balance and determine what level of harm they're willing to tolerate in order for a perceived good. And in terms of justice, really all of us have to continue to act as patient advocates whenever we can in the healthcare system, as well as perhaps within their direct care environment. So as part of autonomy, with values and preferences, these are all tied together in terms of determining what the patient's goals and what their decisions would be. So with Fred, for example, because he really wanted to go to workshop, even though not going at all would have made his medical progress faster. What he was willing to do was to limit his activities for a defined period of time in exchange for still being able to go to workshop for at least 1 hour. every day instead of being stuck on rest for a solid 2 weeks and not going at all. Helen was agreeable to changing her padding and repositioning, and she wanted to do pretty much anything rather than the ideal medical intervention, which would have been to be placed in a bed with special positioning for a week off of the area that was being irritated. So these were very clearly situations where we ask, what do you want? This is what we recommend. How can we meet the needs for your medical condition in a way that's acceptable to you? When there is a guardian that is involved, very often the facilities and staff have to communicate the care plan and decisions with the guardian, because guardians are often more involved with acute care cases and cannot make it to office visits. So if there's a situation which is outside of the scope of delegated decision making, then we do have to get involved with the guardian. So in Helen's case, for example, the caseworker contacted her financial guardian to talk about the need for the expense of a new mold for chair padding, which was ultimately adopted. But in Fred's care plan, it didn't really involve a significant change in his care plan, and it was done pretty much with his agreement with the situation. So we felt at that point we didn't have to involve guardian. So what I've done is outline sort of a simple way for helping to ask yourself a series of questions, and what I have put in parentheses after the questions are the issues that can arise when you receive an answer to this question which is not helpful. So if you have someone who can't receive information and there's sensory or language issues, then those have to be adjusted for example. Whether or not the person can remember the information long enough to use it. They may not remember the information tomorrow that they received today, but if they consistently make the same decision using that information today, tomorrow, and the next day, then they're actually able to retain the information long enough to use it. Assigning value has to do with whether or not someone has kind of sociopathic tendencies, like whether or not they think it's actually good to torture small animals, for example, would be a sociopathic tendency versus one which is a value generally accepted by society, where it's not acceptable to torture small animals. Whether or not the person has intact brain function for decision making, which usually lives in the frontal lobe of the brain. Whether someone understands the outcomes of their decision, they can reason, they can apply it to themselves personally, and are psychiatrically intact without being massively depressed, for example. Whether or not the person is able to, again, communicate their decision, and again, if the decision is generally socially acceptable, whereas murder and suicide are not. In Florida, applying informed consent is covered under a specific statute, and the persons who are allowed to be the spokesperson for the patient have definite rank orders, where the guardian appointed by the court is the most restrictive and complete authority, and it goes down in order of sort of lessening authority as you go down the slide. A legal power that has been granted, someone who is designated as a health care surrogate but has not necessarily been actually named as such by a court, a proxy, which is in the order specified by law if there are no documents in place, and Fred, for example, has a guardian, whereas Helen makes her own decisions that are then verified with her caseworker regarding the ability to implement. Above, the guardian that I mentioned is a financial guardian. She is her own guardian of person, which are separable in Florida law. So determining who is the spokesperson for person versus property, keeping the information, the documents, and the care plan, and then documenting all the decisions that are made and all the legal persons with whom you have been in contact are critical for it. For advanced directives, the 5 wishes is a document with which most people are familiar. that provides some guidance in expressing people's wishes and taking their values as part of what's being done. My Wishes is actually a version that was developed originally for the pediatric population and has more everyday language, but actually follows through many of the same categories of the 5 wishes and includes some nonverbal forms of communication, such as drawings, which can be really helpful for having people with limited communication skills provide their preferences to you. It is not considered a legal document in Florida because it was originally developed for children, but the 5 wishes is actually considered a legal advance directive. So what I've put on this slide are some of the references where you can access some of this information, and for the 5 wishes and My Wishes, those are actually both available on the My Wishes and 5 Wishes website. So at this point, I'd like to stop and turn it back over to our moderator for any further questions for either myself or John. Thanks.
Thank you, Alice, so much. Thank you very much. Can you hear me okay?
Yes, I can.
All right, great. So we do have a couple of questions. We've added a few to the end of the presentation here for John, and we have a couple for you as well, Alice. So I think for the first one, let's see, Alice, I think this one I'll ask you the first one. This is kind of a one you kind of covered a little bit, but I think it's worth reiterating here. Well, I'll just read you how it was phrased. When does self-determination end? And they qualified this by saying, for example, if a patient is their own guardian but doesn't understand the situation enough to give informed consent, as in they need a surgery but they don't quite understand the risks, how do you handle that?
I usually try to do what's called supported decision making, which means having someone that the patient trusts and who is accustomed to assisting them with decisions or with other important aspects of life come in and listen to a similar explanation of what is going on. It sometimes occurs that that person is more effective at communicating with the patient in a way which makes sense to the patient regarding the risks of the surgery or regarding the possible outcomes. And if the patient is able to express a basic understanding of what needs to happen, what the risks are and what could happen to them if things aren't successful, and then is able to indicate a decision, then I generally still try to go with the patient's preference on that. Occasionally, in a really serious situation, the patient may indicate that they want someone else to make the decision for them, even if they are their own guardian, and they may actually delegate someone that they regard as being able to better negotiate the healthcare system to do that. And if they clearly express that to me and I document that, then I'm able to have that conversation with another individual.
And Alice, do you, when encountering this situation, is this, it's sort of it's a difficult situation when you have to come to that determination that perhaps you need somebody else to step in and provide that consent. Is that something that you come to sort of with a group process, or is there some sort of standardized technique that you use, like giving well, I don't know that you would do this, but a mini mental status exam or something like that, where you can say definitively that the patient you're working with can't quite give informed consent, or what's the process by which somebody would kind of arrive at that decision?
Well, the first thing to ask yourself is where the medical situation is so severe that it justifies potentially overriding the patient's wishes. Mm-hmm. And so that usually involves a situation which is the sort of the catchphrase is a direct threat to life or limb, mm-hmm. Where the person would risk permanent loss of a body part or an extremely severe illness which could potentially kill them. Anything short of that, you have time to work with. So you may not get a decision that you think that you can support that same day. You may have to have a conversation over 3 or 4 different visits with 3 or 4 different types of persons there to help with the understanding. But then the second aspect of that then is whether the information that's being expressed is just simply much too complicated. And you'd be surprised. There are not all that many things that are that complicated. You can usually put it in terms of whether or not this is going to make you feel really sick, but if you don't do this, then you're going to lose your leg or something like that. And really make it extremely clear if you think of the final outcome of whatever it is you're proposing to do. Someone does not necessarily need to know that it's going to 12 weeks of treatments 3 times a week where they'll be lying down for 2 hours in order to understand what the basic outcome of a proposed treatment might or might not be. So part of it is whether some of your explanation just has to do with making yourself happy or whether it's really essential for what the patient needs to know. Then after that, it comes down to a matter of knowing what if they've had testing for baseline cognitive ability or not. And if that has determined that they are capable of decision making, it doesn't really matter what your own mini mental testing is. I want to emphasize that this is different than when someone is so sick that they're in a delirium, which can happen to anyone. If someone is in such severe pain or so medicated or has such a severe infection that they can't comprehend what's going on, then in those situations you would have to go with a proxy decision maker, whether you were Einstein or whether you were someone who is having communication problems or whether you were someone with developmental delay.
Okay, thank you. That's a great explanation. We have a couple questions for John that we've added to the presentation. Alice, would you mind, do you have that question? Could you advance the slide?
Yeah. Is this the first one?
I think that it is, and we're just going to try this here. So the first question is for John. What specific accommodations and supports do USF physicians provide to you? So can we hear that?
They treat me like rest of the patient, meaning they talk to me as adult and they work hard to see my needs are met. For example, I was there for my podiatrist appointment. I told them about my knee and they got me in their orthopedic specialist that day. But when they want to do tests or x-rays, I bring my personal care assistant. For routine checkups, I will go by myself with my communication device. Use Physicians Group provides fast care. That means they can see me the same day I call or whenever, but they can't call in antibiotics before seeing me, and that is downside.
That makes a lot of sense. Let's do one more. I think we have another question. Alice, would you mind advancing to the next slide?
Okay.
All right. So this question was for John also. How often do you go to an office visit? You're a family physician, and how do you go to any specialists other than an allergist? Or do you go to any specialists other than an allergist? Sorry.
They treat me like rest of the patient, meaning they talk to me as adult and they work hard to see my needs are met. For example, I was there for my podiatrist appointment. I told them about my knee and they got me in their orthopedic specialist that day. But when they want to do tests or x-rays, I bring my personal care assistant. For routine checkups, I will go by myself with my communication device. Use Physicians Group provides fast care. That means they can see me the same day I call or whenever, but they can't call in antibiotics before seeing me, and that is downside.
I think we got the...
I go to my family physician every 6 months, but if a problem comes up, I go in sooner. I have a gastroenterologist for my acid reflux, and I have a podiatrist for foot care. They work hard to see that my needs are met. My health is good except for high blood pressure and high cholesterol, but they are under control by medicines, and besides I am very picky what I eat. I go with my own power wheelchair because the use physicians are close by my home and transportation takes too long for me.
I think we're back to the previous
For
question
example,
again.
drivers are overbooked and I have to wait for them to get there for at least an hour or two.
Try the next
It
one.
takes me in my chair about 20 to 30 minutes. Traffic does not bother me because I drive safe and I use the crosswalks. Heat does not bother me because I have to do what it takes to be independent. I will use the county van if it rains and if it is very cold.
Well, there we go. So, sorry, folks, we sort of jumped the gun on that last one, but that last question that John answered was about what type of transportation do you use and is it reliable? So we'll leave his answer up here, which you heard, just so you can read it again. In the meantime, I'm going to ask, Alice, I'm going to ask you another question. This one is about accommodations at clinics and such, and it says most primary care docs in the community and at the majority of teaching hospitals nationally, unfortunately, do not have accessible areas, the right-sized doorway widths, height, adjustable exam tables, etc. Nor do they have flexibility to schedule extra time for visits. What to do about these other barriers both patients and providers struggle with? What do we do about those things?
Well, with the time slots, what we'll often try to do, and what I did in one of my previous practices, was to try to give people the time slots in the very beginning of the day so that people would have time to arrive early and we could accommodate some of the time needs there. And then on the other end, to try to give people the time slot right before or after lunch so that, again, you have a little bit more flexibility in your schedule. It's generally not a good idea to schedule people at the very end of the day when everyone's tired, and I have yet to meet the person who isn't running late by the end of the day. So trying to use those bracketed times can help you sometimes with the extra time requirements, or if you have a physician extender like a nurse practitioner or a PA that you work with, that can be very helpful with double teaming. In terms of the physical environment, the other thing that we sometimes have found helpful is to use what people often have as a procedure room or a equipment room, for example, where they do EKGs in their office or things like that, because those rooms are typically larger, and when you know in advance that you're having someone on your schedule who's going to need a little bit more space, if they come in their own transportation and then you can keep a single stretcher style transfer device in your office, then you can actually transfer people on arrival to help get them into the space where they can be examined more successfully. Because the narrow doors are particularly a real problem with some of the motorized wheelchairs.
Yeah. Yes. Okay. Sorry, I was trying to condense this other question for you, which I'm just going to give you the background here, but I think it's a good one. It comes from a parent, so it's a little different perspective, and I'll just read the whole thing. My son is a young adult who is on Medicaid. He is nonverbal and has severe cognitive impairments as well as neurological issues relating to motor skills and seizures. I'm his mother and guardian. Until we went on Medicaid, he had excellent medical care from a group pediatric service who knew him and the family well. They did not take Medicaid, however. At that time, he was on our family insurance policy, but that is no longer an option. We are having trouble creating sufficient relationships with new physicians to get adequate care. They aren't used to working with a parent, and they don't give enough time. As a Medicaid patient, he gets less time than others when he actually needs more. So the question is, I'm wondering what I, as a parent, can do to support the development of better relationships between my son and his doctors.
That's a great question. What a lot of physicians feel is very frustrated by the situation also that this family is in, because most people don't want to have to shortcut people, but if you are a provider who is one of the only folks in town who is actually taking care of Medicaid patients, then you tend to get a lot of individuals who need a lot of help. Something which is really helpful is to try and provide information in advance which people can consider that they don't have to digest as soon as they walk in the room. So if someone has, for example, a patient portal where you can communicate by email and send them some information in advance about the reason for the visit so that you don't have to take the time during the visit to go through all of it, that can be really helpful. If you keep a diary or if you keep a question sheet, that can also be really helpful. When, again, I was working in another environment, I had one family that was absolutely great about bringing a current medication list with them and then bringing a piece of paper that had their 3 major questions for the day and handing it to the nurse and keeping a spare copy for themselves in case the nurse lost it on its way to me. So that they had something that they could take notes on, and I would have something that I could take notes on right away and know what their major concerns were as soon as I walked in the door. And I could look at that ahead of time and be prepared to deal with that. It's not an ideal situation, but gathering enough information to do a good job and to respond to you and your son are probably the key factors that provide frustration all around the map. And knowing that you appreciate that they're trying and you're doing your best to then give them the information that they need to help you is really the most valuable thing that you could do.
You know, I approach this from a different angle as well. You know, in terms of, I think everything, Alice, that you said in terms of interacting with the medical field is right on. One thing that parents can also do is get involved in parent advocacy, and you can start to, you know, you can become a powerful lobbying force, and you can start to do things like help get the Medicaid system changed, get the reimbursement systems changed so that people with disabilities, when they see physicians, you know, aren't hindered by those same constraints that you know, other patient populations might be. And so I've seen very successful family groups get together and make changes to their local and state health systems to better accommodate people with disabilities. So that's another way that you can affect the system, I guess. Alice, would you mind putting up the very last slide here? I think it's, yes, this is the link for our CME credit. We have come to the end of the evening, and so what I would like to do is just show this slide here on how to get your CME credit for participating in tonight's webinar. First, you just go to the link on the screen. That's bitly.com/PEDD2012. You just sign in and register there. If you haven't already registered, when you do so, just make sure that you check your spam folder to make sure that you have received the automatic confirmation. If you have any issues, you can go to www.aadmd.org/contact, and you can contact us, and we will walk you through any problems. From there, you can complete the survey and also complete our quiz. Remember, 7 out of 10 is passing. And once you pass the quiz, then a certificate will be displayed, and it can be emailed to you automatically. So I would like to thank all of you for attending tonight's installment of the PEDD webinar series, and I would especially like to thank Dr. Pomidor and Mr. Satterwhite for sharing their experience and expertise with us. And please remember that if you need your CME certificate, just go to this site on the screen. And if you have any questions, you can email me at mattholder@aadmd.org. So please join us next Tuesday at 6 p.m. Eastern Time, when we'll be discussing how to work with the patient support system in more detail. I hope you'll join us, and thank you from all of us at the AADMD. Thank you, and have a good night.